assessment of the brain, assessment of how the patient interacts, looking at different nerves, etc. So the purpose of a neurological examination is to evaluate the patient's mental status, cranial nerve function, motor system, coordination, sensory system, and then various reflexes that we'll kind of wrap up this chapter talking about. Everybody's probably, if you've never had it measured or assessed, at one point you probably dangled your foot off of the bed or off of the table and whacked your knee to sit there and see that reflex that you absolutely cannot control. I don't care how hard you try not to have that knee reflex. You hit the right spot, that leg is going to go forward. But these different things that we're assessing, not every single one, but some of the things that we're assessing can affect the respiratory system. And I will really slow down and emphasize those because obviously that's what I'm going to test you guys on, specifically how it affects the respiratory system. All right, so just some functional parts here of our anatomy. Of course, the brain, spinal cord, that's going to be connected to the peripheral nervous system, which we have 12 cranial nerves, 31 spinal nerves that go all throughout the body, sending signals out and returning signals back, ultimately going back to the brain. In the brain, 3 parts here of the brain. The cerebrum, the largest part of the brain here, controls specific intellectual functions, motor functions, etc. The 4 different lobes, the frontal, parietal, occipital, and temporal lobe. I will point out just a couple of things. Frontal lobe used for higher level thinking. And when we're studying for those tests and trying to process John's sometimes crazy questions and what the hell is he saying in this question? That's that frontal lobe that's being used for processing. Parietal lobe, a lot of times sensory information. You can feel pain. You can feel a temperature being hot or cold. Occipital, what do you think that's controlling? Occipital. Vision. And then temporal, more auditory, hearing. And of course, that's not everything that all of those locations do, but just kind of hitting some of the broad points of them. Now, lesions or injuries to any portion of these areas can affect someone's ability to move, their level of consciousness, the ability to speak or even write could be impaired, emotions, memory, and we understand that with certain diseases and conditions where memory, of course, can be affected. Sometimes it doesn't affect long-term memory, but short-term memory, I can't remember that I just met you. And here I am introducing myself again. Wasn't there a movie about that? I don't remember. I forget. You're all weak. Thank you. The brain stem down here, where the medulla is, the midbrain, the pons. I'm emphasizing this area because guess where breathing is regulated? Down here. Boy, thank goodness it's kind of protected, really kind of hidden here away from the outer surface that perhaps could be damaged. So breathing, heart rate, blood pressure, all regulated there in the brain stem. The posterior portion of the brain, the cerebellum here, responsible for equilibrium, our balance, our gait, if you will. If someone has an impaired gait, maybe it's difficult for them to have good coordination to be able to walk from point A to point B without stumbling or perhaps accidentally tripping over themselves. Spinal cord, again, connecting the brain to basically the rest of the body. And all the other sensory information, all the other motor functions that can be controlled there. 2 specific nerves that are coming off of the spinal cord, the left and right phrenic nerve. I know we've talked about them in the past. Those connect the brain to the diaphragm, that obviously send that signal for us to breathe. Yes, there's 2 separate ones, so one could be damaged, the other one could be fine. Again, it could affect one hemidiaphragm and not necessarily both. All right, so assessing one's level of consciousness, their wakefulness or alertness is important. The content of their consciousness. their ability to think or be aware. Now, that should be something we are maybe unintentionally evaluating every time we greet a patient. You know, it matters. Is the patient can be able to follow my instructions? If I give the patient some education or training to do this or do that when I leave the room, can I trust that they're going to be able to do it, that they have the ability to be able to comprehend, retain, and then do what I've asked them to do? A fully oriented patient, we say, is alert and oriented times 3. Name, date, and location. Now, we all should know our own name, first and last. Go ahead. Go ahead, Sam? No, but Jeremy.
Didn't it used to be times 4, times 4?
That's been in the past. But names, so who they are, the date, and I don't necessarily, because I ask this all the time when I'm going to write the date. What's a date? And I got to pull up my phone and look at it. So I don't mean necessarily specifically the month, day, and year, but we should all know the year, and it may, depending when the months change, it may take me a second to think about it. Oh yeah, we are now in October, to be able to state that. As far as location, what city you're in, what building you're in. I know I'm in the hospital, but I don't know which hospital I'm at. If they rush me via ambulance or rescue, I don't know which one they pick. That's fine, but at least they know they're in a hospital type setting. Different levels of consciousness. I will kind of refer to this. I believe I found on page 100. It would help if I wrote it down. But here's some different levels of consciousness. From being fully conscious, hopefully that's us right now, to being lethargic. Patient is drowsy but partially awakens to stimulation. Maybe me and my loud voice yelling at you when you're starting to doze off in class. Okay, you're in maybe that lethargic state because you've been up since what, 5 in the morning. You've been running around all day. You have hustle out here to make sure you make your 2 p.m. class. Obtunded, patient is difficult to arouse, needs constant stimulation. You really have to keep hitting them on the arm, screaming in their face, basically. To get them to be somewhat awake. Stupor. I didn't say stupid. Stupor. Or someone being stuporous. This is you, obviously I can't point fingers to myself, but you're in another college class where the topic is so boring. So boring. For me, I could give you some college level topics that you're going to put me to sleep in. And it's probably over those arts and stuff things. It's just not my thing. Just not something I could ever get into. But it's 8 hours of having to hear the most boring talk. Picture how you would be. And you can't leave. You got to suck it up and get there through it. Perhaps you would be somewhat stuporous by being forced to be in that extremely boring. Maybe the instructor's monitor.
Maybe like right now.
Going on. I hear that. Yeah. It's documented. It is documented. And then coma, where there's absolutely no interaction. You can do whatever to the patient. They are not waking up, including suctioning them, sticking them for a blood gas. You see the nurse and staff trying to start an IV with the patient. The patient doesn't even flinch, doesn't move a muscle. Now, 2 common conditions we see in hospitalized patients, especially perhaps more or less ICU type patients, is coma and delirium. Delirium just being confusion, moments of lucidity, and then moments of complete confusion, not making any sense to us. And notice what the numbers are. 60 to 80% of our mechanically ventilated patients have shown signs of delirium. Our poor vent patients. One, they're struggling to breathe, and that's why we place them on a ventilator. And now they're going through periods of complete confusion.
Of they're confused on their own, or is it like whatever pain medication that we're
It could be a combination. It could be a combination of all of that. Go ahead, Tom.
Is that, like the ventilator, is there a causal relationship there, or is it just people who are on vents are usually in such poor shape?
There you go. Because they are so sick and so compromised for whatever reason that we see patients that are like that. So it's going to be hard. Some of you guys that work in a hospital may have heard this before. The term sundowners, where patients get their day, you already, with patients get their days and nights mixed up, and all day they're sleeping. We come in on our night shift and the patient's wild and crazy. Like, shouldn't you be sleeping? I thought that was the joy of working night shift, is my patients could be really kind of sleeping and restful, not having to need too much of our services, right? And you have those patients that are complete opposites. But if you think about it, especially in maybe an ICU type setting, how many windows are in that ICU? How many windows to the outside does that patient have? You know, sometimes when you think about it, going, you know, there may be a little thing up in the corner that you can see the outside, but the patient from lying in bed can't. And it's easy for them to get their days and nights confused. Plus, we walk in there, or the staff walks in there and flips lights on, leaves the light on. No wonder they get their days and nights mixed up. Again, that's part of that delirium or confusion. And yes, it could have something to do with the medications that they're giving, side effects of medications. It could be them just being oxygen deprived and the brain being oxygen deprived. And so, you know, cognitively, they're not as sharp as they normally are when they're in a good, healthy state. Some patients that recover from their initial severe neurological injury may recover to the point that maybe they can breathe on their own. The normal bodily functions are still present, but neurologically, they might not necessarily be there. We've all probably heard of patients being in a persistent vegetative state. That could be a patient who's still on the ventilator. Everything else is working right, but they need that assistance of the ventilator to keep them breathing. But there could be even patients that get weaned off the ventilator, but still there's some significant cognitive problem or issue that's leading to them to be in this kind of persistent vegetative state. And obviously with that carries an extremely poor prognosis. More than likely they have the inability to protect their own airway from their own secretions. And so they could easily aspirate, develop a aspiration pneumonia, an infection, and then maybe that's what ultimately causes their ultimate demise. All right, the Glasgow Coma Scale, an extremely commonly used instrument, if you want to call it that. It's kind of a rubric to quantify someone's level of neurologic impairment, especially individuals who've had head injuries. So some sort of trauma, some sort of traumatic event where their head took a significant impact. It could be a fall, it could be an MVA, a motor vehicle accident, something where their head really was compressed, where their head was really damaged. It tests for motor response, verbal response, eye opening. And so some things, especially as it's related to verbal response, it might be difficult to evaluate a true Glasgow Coma Scale if, let's just say, the patient doesn't speak English. Okay, it would be hard for them to follow my instructions if they don't understand what I'm saying, or if they're hard of hearing. Again, our elderly patients, they come in, the hearing aid they did wear is now left at home or whatever, and so we don't realize that maybe initially, that the patient just can't hear me. I'm talking in my normal tone of voice because I don't want to feel like I'm yelling at the patient, but the patient needs me to raise my voice so they're able to hear me. So different things like that could make assessing the Glasgow Coma Scale difficult. Now, the scale runs from a score of 3, that's the absolute lowest it could be. This desk, your pencil or pen, has a GCS of 3, just so you know. The best it could be is 15. Okay, now I'm not going to ask you to sit there and, I'm not going to ask a test question where I'm asking you to solve or give me the Glasgow Coma Scale when this is how the patient presents. I do expect you to know what kind of normal is and what's the lowest. Again, what's the lowest score?
3.
3, not 0. Okay, so when I say what's the lowest possible GCS score one can have, obviously I'm going to give 0 as an answer option. See how many people I can sucker into picking 0. No, the lowest it can be is 3.
0 is like you're already the man upstairs.
If you look, eye opening, there's no response to their eye opening. They still get a score of 1, right? Verbal response, no response to any sort of verbal stimulus, a score of 1. Best motor response, no response, 1. That's the desk you're sitting at, the chair you're sitting on. It's absolutely 0 response, right? So that's where your lowest score could be 3. Now, patients with scores of 12 to 15 typically do not require intensive care services or an ICU admission. Any scores from 9 to 12, again, possibility that they could require ICU levels of care. But any scores, remember this, these numbers are two numbers, 8 or 9, anything below that typically means the patient's not able to protect their own airway and would require intubation. Now with that intubation, they'll obviously need that endotracheal tube connected to a ventilator. So I'm not saying scores of 8 or 9 require a ventilator. It's not the ventilator, but they do need the endotracheal tube to do what? Protect their own airway.
So would it be potentially possible to have a test question that would be, what is the scale?
Absolutely. That's a very good one. I'm glad you asked that, Chad.
Okay.
Okay. So know what the number is that would indicate intubation, because obviously that's
Is that going to be
that's
8 or
our
9, or is it going to
forte.
be 8 or 9?
So we're not gonna
Yes,
have to.
all the above.
Okay.
So we're not gonna have to like give a specific score to a test question or like no.
Correct,
or
correct.
no
I'm not giving you a
this.
scenario where you're gonna have to sit there in your head, add up, and okay, is that a 2, is that a 5, is that a 4? I'm not doing that to you.
Okay.
Know what the scores mean though. Obviously, I want the highest score possible, but if it's starting to fall, that's indication of significant neurological impairment for your patient. And what sort of patient is this that's typically being evaluated? Patient with a head injury, head injury. All right, here's another rubric or another survey or test. Again, you don't have to know all the specifics, and I don't even know if you can even read that. I'm standing right in front of it, and I could barely read it. But the textbook didn't give you this. It gave you the title of it, but it didn't give you the specific questions. But the mini mental state examination, this is not a state of Florida thing, it's just funny it uses the word state in here. A 30-point, not 30 questions, but a 30-point questionnaire to assess a patient's level of cognitive impairment. See this performed sometimes on dementia patients, and to gauge their level of impairment. So, for example, this first one, and you don't have to know these specifically because I'm not going to ask them, but what is again, imagine this is you talking to your patient. What is the year, the season, the date, day, or month? Okay, you might not be able to tell me that, or can you tell me some of it? You're able to answer those questions accurately, that's a score of 5. Next one, where are we now? What state or county or town or hospital or even floor? Now some of these, I can understand the patient might not know some of these. They don't know they're on the 5th floor or 4th floor, etc. But they should know what state they're in, what city they're in. Again, to answer those, they get a score of 3, and so forth. We can go all the way down this. How about this one? You be honest. Tell me if this is you. I would like you to count backwards from 100 by 7s.
Yeah, I'm going to get that by 2.
93, 86, 79. I'm going to have to say, hold on a second. I'm going to be a little slow at this because I'm going to do the math in my head. But a score of 5. Or how about this? Spell word. They just picked this word. World backwards. I'm gonna say you're gonna have to give me an easier word. How about cat or dog? I'll spell that backwards. But again, to get a score of 5. I skipped over this one. The examiner names 3 totally unrelated objects to see if the individual can remember it, and then later brings them up. Remember those 3 items? Can you tell me those 3 items again? Again, we could all answer that. Again, the counting backwards 1 by 7 could be a little more challenging, but I think we could all do that. Ultimately, you get through all these questions, you count up your points. Now, normal score is anywhere from a 27 to 30. 27 to 30 is considered a normal score. Any score of 20 to 26, mild dementia. This may be you after not getting much sleep and after a big, hard, difficult test. 10 to 19, moderate. Anything under 10, severe dementia.
Admit me.
So you want us to know the score interpretation, but not.
Well, I would make sure you remember what normal is, but what's the purpose of this examination or these tests?
To assess the cognitive.
There you go. There you go. Again, I'm not getting nitpicky on these things, so. I think you're lucky to start on that one. Here's another one, the Richmond Agitation Sedation Scale, RASS for short, R-A-S-S. This is funny because this is something we talk about in this class today, and I'm not sure we ever bring it up ever again throughout the program. The reason I say that is because I had a student who had graduated, took their board exams, and a lot of times students will reach out to me after to give me the good news or the bad news, if that's the case, how their board exam was. And a student said, John, I passed. I'm like, congratulations, awesome. What'd you think? And I asked my usual question. What'd you think of the test? How much math did you have? Blah, 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 blah. How many pharmacology things did you have? All these questions that I get nosy and ask so I can turn around and share. Well, that student said, I got a question. They asked a question I've never heard of before. What's an RASS? And I said, well, you remember week 8 of the first semester? It's the one and only time I know I talked about it, unless you saw it out there clinically, and I can understand why something like that can slip. And another thing, the test only gave the initials. It didn't define what the initials are, and I've noticed that MBRC is notorious for just doing initials and not defining them. I know on my test, I may give you the initials and I may still write it out and give you the initials after it, try to just to clarify this is what I'm talking about. Anyways, it's to assess a patient's level of sedation or consciousness. Now, picture this is you're the RT, you're a brand new RT, and this is your patient you're taking care of. Would you rather have your patient having a score of +4 listed as combative, that they're violent and carrying immediate danger to the staff? You know, they pay me well, but they don't pay me enough to get beaten up, right? 3 is very agitated. You can see pulls or removes tubes or catheters. Patient is aggressive. You know, pulling tubes like endotracheal tubes. Agitated, frequent non-purposeful movement, fights against the ventilator. And I would say that would be any one of us if I placed you on a ventilator. And the ventilator said, no, you're not going to breathe like we've set, or you're not going to breathe like you want. The ventilator is going to breathe like it's been programmed. 1 breath every 5 seconds. Volume doesn't change. You're going to get this whether you want this or not. You would fight against the ventilator too. You wouldn't like that, breathing that way. Everything's very programmed. Again, whether you wanted that breath or not, you're going to get it at a very strict or structured interval. Restless, anxious, but movement's not aggressive, not vigorous. How about 0? Alert, calm, spontaneously pays attention to the caregiver without creating any sort of violence whatsoever. As you go down the scale, obviously drowsy, the patient's a little more out of it, not easily is awoken, all the way down to where they're -5, completely unarousable. Now, if this was our patient, say in an ICU setting on a ventilator, we're hoping probably more of maybe a -1. Keep them drowsy. And remember that if you're ever my respiratory therapist managing me on a ventilator, -1, maybe -2, just depending on the day, right? Because I don't want to remember any of that, and neither would your patient. Until it's time to extubate me and get me off the ventilator, then go ahead and make sure I'm completely awake and alert. But that in-between time, as I'm recovering and trying to recuperate, keep me comfortable. And so all this is assessing whether the sedation that's being provided is not enough or is it too much. And there is, to be honest, there is a happy medium where we need to keep the patient comfortable, but not completely knocked out 100%.
Those have like monitors, like sensors that do kind of.
Somewhat, yes, yep. Especially when it comes, and we'll talk about this in time, when we purposely paralyze a patient. And there's going to be times we have to have a patient completely 100% paralyzed, or they can't move a muscle. And that's okay, because they're connected to my ventilator, and my ventilator will take care of their breathing and do all the breathing for them. But I want to completely take the patient out of the equation right now, and let the ventilator do the work, let the ventilator provide all the oxygen, let the ventilator do all the ventilation for that patient, and let's take the next several days, next week, to allow the lungs specifically to heal for whatever reason we had to intubate them in the first place. All right, some sensory examinations could be performed here. Having the patient respond to certain stimuli at specific positions. For example, pain, physician may come in with a very small needle that is uncomfortable, right? I would say it causes pain, but it's not excruciating pain. But tell me if you can feel this, extremities, feet, hands, etc., moving up the leg. Some motor examinations. Again, have the patient, can you raise your right arm? Can you raise your left arm? Can you raise your legs, right and left? If the physician puts their hand on the patient's foot, and tell the patient, can you push down like you're trying to press a gas pedal or a brake? That sort of thing, to assess motor response. Looking at motor strength as well as range of motion will be assessed. Now, if a patient is unconscious, that's when we sometimes do somewhat painful things to the patients to see if they respond. For example, anybody heard of a sternal rub? Again, getting your knuckles and you're rubbing it right there on the sternum. Very uncomfortable, very painful if that was to happen to you. But for our patient, how do you think the patient's going to respond? Not waking up, or are they going to sit up? If they have a response, that should, again, if, quote unquote, they have a response, they should react to that uncomfortable. Another thing, kind of grab your pen. Don't do it too hard, but you can sit there and press down on your nail. It hurts. It's uncomfortable. Squeezing the trapezius, kind of hitting that pressure point. It is uncomfortable, but for a patient maybe who is in a comatose state, that could be something that they assess. Again, really would tell the difference whether somebody's just sleeping heavy versus in a more comatose type state. Posturing, specific postures for the patient can indicate severe brain damage. Two more common ones, again, if we're talking about posturing here from brain damage, decorticate posturing. Notice the body is very stiff, somewhat rigid, but the arms will be bent, the fists will be clenched, legs held out straight. This is our patient, and I'm going to have to get, because the physician ordered it, an arterial blood gas. But the patient's in this position. It's going to be very difficult. Sometimes to the point nearly impossible. I'm going to have to tell the physician, hey, doc, did you notice the position? Unless you want me to get a femoral artery stick, there's no way I'm going to be able to get radial blood from the position this patient is in. Deceribate posturing, in this case, arms and legs being held out straight, similar but straight. Their arms will be pronated, or they'll almost be in this position. Again, another example, what if you have to stick a blood gas? It's going to be difficult to get their arm back, because again, they're kind of stiff and locked in this abnormal position.
Would you not want to try to sedate the patient more, because it's not possible?
This could be with or without sedation. They are in
Oh.
this posturing type
Even
position.
with how locked and stiff their muscles are,
Yep.
they wouldn't relax.
They would not. They would not. One of my first blood gases ever as a student was a patient in a deceribate posturing position, and they still wanted us to try. And so it was a challenge. I'll never forget that gentleman to this day. Deep tendon reflexes, like the knee jerk reflex. Again, all of these different reflexes, depending on what we're doing, we're evaluating different spinal nerves. So knee jerk's one that's fairly common. People may recognize it or remember it. Any patient with a potential spinal cord injury. So think of any patient in any sort of traumatic type event. There could be issues with spinal cord injuries. A variety of reflexes will be assessed. Again, depending what we're testing, it could be a bicep reflex, a tricep reflex, patellar, that's the one in the knee, or Achilles. Again, helps to evaluate specific spinal nerves. Maybe the reflex is normal here and here, but here it's abnormal. Lets me know where the injury may be occurring, at what level of the spinal column. Whether it's a cervical vertebrae, your lumbar vertebrae, etc.
So you're not gonna see a physical reflex in those locations if there's damage to.
If there's damage to those specific spinal nerves. All right, the Babinski reflex. Again, they're on the bottom of the foot, kind of getting the back end of, for example, it could be a pen, but generally you'll see the physician use the back end of a reflex hammer, the same hammer they're whacking your knee with or doing some of the other reflexes. They'll turn it over, and from the handle's kind of a cold metal piece, and kind of drag upward on the bottom of the foot to see if there's a response. Again, generally is tested in comatose patients. Normally causes the foot to kind of flex, curling of the toes, but if it's a positive Babinski, it causes what they refer to as dorsiflexion of the foot with fanning of the toes. That is actually a normal reflex in children 12 to 18 months of age. But for an adult patient, that would be considered abnormal. If that's the case, then it could be some sort of lesion or upper motor neuron damage. They're part of the brain. All right, speaking of the brain, brainstem reflexes. I'm sorry.
If,
I didn't know that was
If a patient is considered like brain dead, are any of these reflexes going to happen?
correct. No,
No?
no. Or they will be impaired. And I'm going to talk about brain death in just a minute.
So like going through, like if somebody just goes through and tests all the cranial nerves, is that just like a good way to, I guess?
It's part of the picture. It's a part of the picture to assess brain death. It doesn't mean 100% that patient's brain dead, but it's part of the assessment in that scenario. All right, so brain stem reflexes. Okay, reflexes coming from the brain stem. These are evaluated with patients who are lethargic or comatose to determine whether the brain stem is intact. Now, I put these in bold for a reason. I'm not getting nitpicky on those other spinal nerves or anything like that, but I am on two particular cranial nerves. Cranial nerve number 9, that's 9, and cranial nerve number 10. Now, cranial nerve number 9 controls the muscles of swallowing and whether the patient could aspirate or not. This is evaluated by testing the patient's gag reflex. Physician will get a tongue depressor, stick it in the back of the throat. What should be a normal response? The patient should, thanks for the visual, the patient would have that gag reflex. Again, that's a normal reflex, that's a good thing to let me know, hey, if secretions or fluid or anything like that got back there, the patient would have that gag reaction to try to keep that out of the lung. Cranial nerve number 10, that controls the cough reflex. Now we see that when we suction our patient and they respond appropriately. Trust me, if I stick a suction catheter down your throat, you are going to cough and respond appropriately, thank goodness. But there are going to be those handful of patients that you go down with a suction catheter and think, why aren't they coughing? Again, their cranial nerve number 10 is not functioning proper. So whatever's going on with them, that cranial nerve is being impacted. So if it's number 9 and or number 10, those are all patients at risk for aspiration. And again, ask yourself this question. The patient's intubated, and we're trying to determine, based on other factors, but one thing we're looking at is, well, if we take the tube out, if we extubate the patient, will the patient be able to protect their own airway from their own secretions? You know, if I'm trying to suction the patient and they're not responding, do you think it's a good idea to extubate the patient today? No, because again, I'm going to extubate them. That's protecting their airway from aspiration or secretions. Now I extubate them. Now I'm going to allow the patient to aspirate? Of course not. So that's part of the evaluation when it is time to extubate a patient is, can the patient protect their own airway? Or do we need to leave the tube in so the airway is at least right now protected?
If there's damage to those two kind of nerves, is there a way for the patient to come back from it or no?
It depends why. Could it be swelling, inflammation? okay, maybe we can reduce swelling inflammation and those reflexes would come back. But if it's because of brain damage, then no, that might not be something that could recover from or come back from. All right, still looking at cranial nerves. Now I'm not getting nitpicky on some of these cranial nerves. The previous slide, make sure you know 9 and 10. But looking at pupillary reaction. Now we know what happens when we're in a dark room and somebody turns a light on or flashes a flashlight in our eyes, how our pupils would respond, correct? Or if I turn the lights off in the room, turn the projector light off, it gets really dark in here, we know our pupils will dilate. We understand that. But things that can be assessed using that same concept. Again, PERLA, pupils equal round reactive to light accommodation. If we were to shine a light just in your right eye, both pupils should constrict. All right, both pupils should constrict. If you're having issues here with cranial nerve number 3, shine a light in a person's eye, that eye constricts, the other one doesn't. Lets us know there's something wrong with specifically cranial nerve number 3. If we shine a light in the patient's eye, it doesn't constrict, but the opposing eye constricts, lets us know that's a cranial nerve 2 lesion. Problem with that specific cranial nerve. Different things looking at cranial nerves 2 and 3, depending what happens here to the eye. One pupil could be larger than another, could be pinpoint, could be dilation. Now I will say sometimes these things could happen based on drug usage or medication usage, so that's not an entirely 100% foolproof way to say this patient has brain damage or not, because maybe it's medication induced. But if they talk about the eyes being kind of in mid-position, fixed, often indicates severe cerebral damage. So sometimes you will see during code blue resuscitations where they will be evaluating the eyes. And we're still in the middle of a resuscitation. We've been doing this resuscitation for 30, 45 minutes now. They may look at the eye. Again, what are they looking for? To see if there's severe cerebral damage.
Is that why they look at the eyes when you have like a concussion? Like
Part of it, yep. Again, head injury.
Yeah.
Corneal reflexes, this is looking at cranial nerves 5 and 7. Picture yourself doing this. How do you think you would react? Getting a cotton swab and wiping it across your eyeball. Punch, right? Do I need to tell you the normal response is blinking of both eyes, right? Of course you would not get that damn cotton swab out of my eyeball, that hurts. Or a Q-tip, think about the cotton on the end of a Q-tip gently touching. Yeah, it's gonna be irritating. We would blink. But what about patients with brain damage? They might not have that same reaction. A lot of these things, think about how you would respond, how you would think you would respond. And obviously in these examples, the patient's not. Oculocephalic reflex, otherwise known as doll's eyes. You may see the physician go to the head of the bed, have the patient's head in their hands, and they will have the patient's eyes open. Again, the patient's not able to interact very well. Look at the patient's eyes, and they'll rotate the patient's head from side to side to see what their eyes do. How are their eyes turning? If you turn the patient from one side, their eyes will look the opposite, and vice versa. Okay, so you turn the patient's head to the left, their eyes are going to look back right. That's a normal response. If they turn the patient's head side to side and the eyes stay fixed, they describe it as why the name doll's eyes. Think about your doll from childhood. Their eyes aren't turning or moving. They're staying exactly where you turn their head to.
So they're gonna say like, keep your eyes on me while I rotate your head?
Well, the patient's not really interactive. They will have the patient's eyeballs open, or eyelids open so they can see the eyeballs as they make those turns. Oculovestibular reflex. This is the injection of cold water into the patient's ear.
Oh my God.
very painful when that is done. Now, if a patient does have the reflex, how we would respond, aside from punching or swinging, going, stop doing that, when that cold solution, that cold water is injected, and it's not 20 mLs of ice water, so it's cold, injected into the ear. Notice where the eyes look. They look at where the pain is coming from. If they have a brainstem injury, however, they look forward. They never look where the cold water, that ear, wherever that cold water is being injected. That would be an abnormal response, abnormal reflex.
Does that cause like patients to fall out or faint sometimes?
No, again, these patients are not really interacting with us, okay? They're not able to follow commands, they're not able to interact. Comatose or just slightly above comatose type level. And so as far as having a conversation with them, not really. Not being able to make any semblance of sense. But this is, okay, they're not interactive, they're not responding to pain, any of those reactions. These are some of the reflexes, again, to assess cranial nerve function, brainstem reflexes. Now, the chapter does mention control of breathing, which I'm going to refrain from discussing in this particular class. You can thank me later. But we do discuss this topic in the cardiopulmonary A&P class in a couple of weeks. And so I don't want to sit there and double dip and teach it twice. So I'm going to refrain from this part and kind of save it for the cardiopulmonary class. We have a whole chapter on this as opposed to just a couple of pages this chapter dedicates to the control of breathing. So we will get into this in due time, but I'm not going to talk anything about this, nor am I going to test anything about this in this particular class right now. All right, some additional testing of the neurological system: imaging, CAT scan, MRI. Again, CAT scanning gives us very clear, good imaging, but MRI gives us even better imaging to see perhaps the vasculature, blood flow going throughout the brain. Again, can be something that's used to assess and make sure there's adequate perfusion or blood flow reaching the brain. Again, this will be another indicator when we talk about brain death. Is there even blood flow going to the brain? EEGs, electroencephalogram, again, looking at brain waves. Again, if there's adequate perfusion, adequate function, there should be good electrical activity there in the brain. Sometimes patients who are having seizures or seizure-like activities could have an EEG done to see if it's truly seizures or if it's something else. Sometimes I'll call them false seizures, where the patient's reaction is very seizure-like, but it's not necessarily caused from seizure. Lumbar puncture, again, assessing cerebral spinal fluid. We'll get into that a little bit later in another class on another day. This is next semester I'm talking about, in some diseases, some neuromuscular diseases, that test may be performed to look and see about what's in the cerebral spinal fluid. It could be elevations of proteins, could mean one thing. It could be infection, could be something else. But that's just another part of a neurological exam.
We're not going to be tested on that.
Not generally, no, other than just the very simplistic, the lumbar puncture, looking at cerebral spinal fluid. All right, intracranial pressure monitoring. Now, when you begin spending some time in the ICUs, especially in our hospitals that see lots of trauma patients, you will get some experience in seeing patients with intracranial pressure monitors. Now, these are monitors that can get placed inside of the skull. When you see it placed, sometimes it could be very dramatic. You're like, holy cow, where are they going with that drill that they're drilling into their skull? Again, to put a probe to monitor pressures. With a head injury, if I get any injury and there's swelling or inflammation, you could see my arm swell up or my leg swell up, whatever. If somebody has a significant head injury, the head doesn't swell like that, would it? That'd be the weirdest thing if it did. Why doesn't the head swell this way? Well, we have a skull that's keeping everything down, but the head could still swell. Where will it swell? Back down on the brain stem. And so we want to make sure pressures are not excessive. Now again, this typically we see more with the trauma type patients that have had some sort of head injury, significant head injury. And so we can look to see what the pressure is in the cranium. By knowing that, what the intracranial pressures are, we could then evaluate cerebral perfusion pressure. Now, what's the reason for all this testing anyways, all this evaluation of intracranial pressure monitoring? Is to ensure there's adequate cerebral, when I say cerebral, I mean brain, blood flow. If the pressures are allowed to get too high in the brain, guess what will then be limited? The amount of blood going to the brain. If the pressures are too high in the brain, the body's trying to pump blood throughout the body, right? But if the pressure is too high up here, guess where the blood's not going to get to? It's not going to get to the brain. And obviously, for a patient to survive some sort of significant head injury, trauma injury, you have to get good perfusion to the brain, for obvious reasons. But what I mean, and again, I'm don't want to get too far ahead of myself here, but when intracranial pressure, the pressure here in the cranium, approximates that value the same as mean arterial pressure. If you think about our blood pressure, what's the normal blood pressure? 120/80. That's a mean, if you were to calculate an average, that's a mean of about 90 millimeters of mercury, the 120/80. That approximates about a mean of 90. And so if intracranial pressure is that usually I can count on one hand what a normal value is, right? Generally a single digit. When it gets over 10, then we kind of say that's a little abnormal. Gets over 20, we really get scared. But if that number gets close to what my mean arterial pressure is, that means good luck getting blood flow to the brain. It's not likely going to happen. And so it's why we measured that intracranial pressure, to be able to make sure we know what that pressure level is. And if we see it's getting higher, is there certain interventions we could do to help try to keep that pressure down? To, again, ensure there's adequate cerebral blood flow. And that's what I mean when you hear the word perfusion, that means blood flow, right? I want to make sure there's adequate blood flow getting to the brain. And if intracranial pressures get to be too high, that's going to lower cerebral perfusion pressures, which means not enough blood flow is going to be getting to our patient's brain. And then all hell's going to break loose if that happens, right? All right, last part here, last couple slides. This is on brain death or brain death determination. Of course, I think we all understand, we all heard of the word before, but brain death is an irreversible condition where all perceptible brain activity has ceased. There's nothing going on there. They may still have a heartbeat, they may still trigger our ventilator, but there is really and truly nothing going on up here. And so at that point, we're going to do a brain death determination. Let's see if everything is, no longer ceasing up here. And so usually from someone that we see with a severe brain injury, now this of course could be your severe trauma patient, significant head injury type patient, but it can also be someone who was a prolonged cardiac arrest or someone with a severe stroke. Now let me step back to talk about prolonged cardiopulmonary arrest or cardiac arrest. When someone goes into cardiopulmonary arrest, what does that mean for their ability to breathe? It stops, so they're not breathing. What does it mean for their heart rate or heartbeat or their blood pressure? Stops. So when we resuscitate them, obviously we're doing chest compressions to get the heart rate up. We're doing compressions, making sure it's adequate depth to try to make sure the blood volume pumping out of the heart is normal. We're ventilating them. We're trying to provide the oxygen and breathing for them to get oxygen into the bloodstream. We're doing chest compressions to pump that blood throughout the body, including getting blood flow to the brain. That's carrying oxygen, right? That's the purpose. That's why we do CPR. But I think I've said this before. Even the best CPR cannot match what you and I normally do when it comes to the cardiac output, the volume of blood being pumped out of my heart. Even with the best chest compressions, we still can't match that. Okay, hopefully we can get something there, and hopefully with the right medication or the right defibrillation, we get things back to normal. But in the meantime, we're doing chest compressions. We're trying to get blood flow, and we're trying to get oxygen into the bloodstream and get it flowing to the body. But if someone has a prolonged cardiopulmonary arrest, the fear is, have they gotten enough blood flow to the brain? And if they haven't, then what does that mean for the brain or the brain's ability to survive this incident? The longer this lasts, the less and less likely positive survivability is. But it's possible, even though we've gone through 30 minutes of resuscitation, that suddenly the heart's beating again. Okay, I'm still going to have them on a ventilator, I'm still going to breathe for them, but the heart's beating again. Oh, did they make it? Did they survive this? Maybe, I hope so. You know, for them and their family, I hope they survive this. But if it's been a prolonged resuscitation, and there's been limitations as far as how much oxygen actually got to the brain, this is the patient that, yeah, we brought them back, but we don't think that the brain survived. We don't think the brain got enough oxygen. And so the likelihood of survivability is extremely poor. And so now we're to the point, they want to do a brain death determination to see if truly nothing is going on up here anymore. The brain was deprived of oxygen for too long, even though they coded in the hospital. You got to pick a best place to code in the hospital when we're there and all our resources are there to get them resuscitated hopefully sooner rather than being down at home for a length of time. So, examination by the physician and some further testing such as an EEG. What's EEG again? And that measures brain wave activity, or imaging study, CT scan, MRI scan, looking at is the brain still getting blood flow. The absence of pupillary or corneal reflexes, gag, the autovestibular reflexes, all those different things we talked about. You can see the gamut. And again, I hate for us to think, oh, man, this poor patient that's going through this testing that is failing all these tests. But it's a neat opportunity if you happen to be there that day and get to see kind of everything we talked about today all performed on this patient. To see, I know how they're supposed to respond, and they're not doing it. These are all bad signs. In addition, the absence of respirations during an apnea test will be almost, I don't want to use the term final, but it will be one of those last confirmations that there is no longer brain activity. Now, who do you think performs the apnea test? Respiratory. So we'll be there with the physician, of course, but we will be doing things to perform the apnea test. And really, it's a test to see if the patient has apnea, right? And if they have apnea, prolonged apnea where they're not breathing, that's an indication of brain death. So, how we perform the apnea test. And again, this is the respiratory therapist's responsibility. You may see, okay, we're going to do an apnea test here on patient in bed 1. Okay, let's make sure we're all ready. The team understands. Everybody that's involved in the patient's care is understanding. You may have everybody that's part of the patient's care team being in that room because we all are rooting for the patient to make it as well. But the patient has an arterial blood gas performed. We're wanting to make sure their numbers are somewhat normal. That's what I mean by numbers are normalized. So they have a good pH, a good CO2, a good PO2. And it's the CO2 I'm really focusing on. I want to make sure that number is normal. We take the patient off the ventilator. We remove them off the ventilator. But we still make sure they're receiving 100% oxygen. Okay? There's different ways to do that. I can set up and you guys know this already, thank goodness now, what a TP setup is. I can give a patient connected to their endotracheal tube. They're no longer on the ventilator. The ventilator has been placed on standby, set to the side. A TP setup with 100% oxygen freely flowing. Now, is the patient doing one of those? That's what I'm assessing for, but maybe initially they're not. And so then we watch. Remember, they're disconnected off the ventilator, and we are watching their chest. We're watching for a breath. A breath. All they need is one. And then, okay, we'll move on to something different. But we're looking for a single breath. But remember, many times we're doing this, we unfortunately see the poor outcome, where we're watching them for how long? 8 to 10 minutes. And the whole time we're watching, they're not breathing. They're not taking a single breath. Again, we're watching the clock. We're making sure we're given plenty of time. We don't see them take a breath. Okay? At that point, we will connect them back to, before we connect them to the ventilator, we will draw another blood gas. We'll look and see what the CO2 is. Now, assuming the CO2 was normal when we started, what's a normal CO2? What's a normal arterial CO2? 40. Go ahead and say 40. Don't say anything else. 40. That's normal arterial CO2. 40. That's where they started. They've been testing to see if they would breathe for the last 8 to 10 minutes. Again, if they're not moving any air, all right, I'd leave them alone. 8 to 10 minutes later, what do you think happens to their CO2? It's starting to rise, right? And so when I do the second blood gas to see what the CO2 is, it's to let me know, yes, the CO2 level has risen high enough that if there was brain activity, that high of a CO2 should stimulate the brain to take a breath, to breathe. Even if it's just one breath. I didn't say it had to be a meaningful breath. It's just one breath, and that would count. Assuming they didn't take a breath. All right, I've done the blood gas to make sure the CO2 did rise high enough, or that it just went 20 above whatever the baseline was. And we'll get into what some of those numbers are a little bit later. But it definitely was increased. CO2 was definitely increasing in the bloodstream, which means that should be a high enough value if there was brain activity. If the brain was functional, that should still be able to send a signal to the diaphragm to at least take a breath.
Would you just continue the testing if the ABG is like abnormal, or you still do?
No, I would still do it. Again, even if I can't get them perfectly textbook normal, I'm at least going to start, okay, this is what their CO2 level is. I will do the test. Patient didn't breathe during the test. I do that follow-up ABG, and I saw that the CO2 did go up at least 20 or more, 20 millimeters mercury or more above where we started, where that baseline was. And again, that's my documentation to say, yeah, the CO2 was high enough that they should have been able to at least trigger one breath. Now, if they don't, then obviously they, you want to call it passed the apnea test. I don't like to use the word pass-fail on this, but patient didn't take a breath. I will put them back on the ventilator, and then we'll go from there as far as how the other tests results came back, the imaging, the EEG, all the different reflexes and stuff that were being assessed. But that's the apnea test. That's the apnea test. And yes, we're there part of it. And we can't sit there and say, okay, I'm doing the apnea test, and then I'm going to talk to this person about something, and talk to that person about something, and never keep my eyes on the patient, right? Because the whole time we've got to keep our eyes on the patient. Because there's nothing connected to the patient that's going to tell me, oh, they took a breath. No, it's me watching. That's why many times the physician may be in the room with us, the nurse may be in the room with us, all surrounding the patient's bed, watching and waiting, hoping that they do take a breath. Again, and if that's the case, then okay, doesn't mean that their prognosis is suddenly wonderful. They still have a long way to go, but at least right now we can't say that they are truly brain dead. Questions? You guys will get that. Again, it's not the most exciting part of my day, trust me, when those things come up. You know, somebody's worst day of their life or their family's worst day of their life. But it's something that we are a part of during those moments. Another thing, that was my last slide, right? Okay. Just one other thing, just to make your day. I hate to finish on some of these so negative, topics. But when the day comes, and yeah, that patient's brain dead, and they've discussed, patient's now back on the ventilator. All the results of that test, plus the other scanning, reflexes, and imaging, and all that other stuff, gets presented with the family. The family has the hard decision to make, of course. And the decision's made, yeah, go ahead and take him or her off the ventilator. Well, who takes him or her off the ventilator? Yeah, it's us, yeah. It's our ventilator, so we have to do that. Who extubates the patient? Who does the terminal extubation or terminal wean? Yeah, that's us. That's us. Yeah, it's, again, not the most pleasant moment of our lives, trust me, but I always say this, and forgive me if I get into this discussion in another class on another day, because it's important. It's important to be able to say, you know, I did this, but the patient is in a much better place now than they were in that ICU with that ET tube and everything else hooked up to them. The person is in a much better place. And again, if you go in with that mindset and feel that in your heart, you'll know, okay, you know, I feel bad for the patient, I feel bad for their loved ones, etc. But the patient's in a much better place now than the horrible situation they were in.
If the family decides to donate their organs, I know they keep them
Sure.
alive on the ventilator,
Yep.
who monitors that? Is respiratory that
Yes.
monitors?
Yes, so the question was, okay, so assuming the patient did not, the brain determination came back, yeah, the patient is truly brain dead, and the family decides to do organ donation or organ procurement. Yeah, the patient's still gonna be on the ventilator, we're still gonna maximize their ability to oxygenate and ventilate, we're still gonna do everything to keep the body, you know, alive and surviving and everything else. And when that happens, they bring in the organ procurement team that then takes over the care of the patient. And so instead of necessarily the patient's physician saying, oh, let's do this, let's do that, it's the organ procurement team that comes in and says, okay, let's adjust the ventilator to this setting or that setting to get them ready for the organs to be, sorry, I'm not trying to sound negative here, but it's the verbiage, harvested, so it could be, you know, given to someone else.
So until they go to OR, will be respiratory.
Yep. And we may go down to the OR with them, not to stay in the OR, but to deliver the patient, or the OR may come up and might take the patient from us. Either way, we're gonna be right there during all of that. You do know that the organ I have to slow down when I say it. Procurement team does have respiratory therapists on their staff. So it's something to consider if you're looking for something a little bit different than the standard hospital setting. But do they only work Monday through Friday, 9 to 5? No, round the clock, because you never know when a organ is going to have to be, you know, harvested. And unfortunately, accidents don't happen just Monday through Friday, 9 to 5. Happen all the time. All right. Any questions before I go to your practice questions here? I think I gave you. Okay. I gave you four. Of them. All right. So, first question is this. Knowledge of neurologic function is important to the respiratory therapist because A, the RT is often the first healthcare professional to encounter a patient with a stroke. B, the RT is an important member of the neurology clinical staff. Many central nervous system conditions also affect the respiratory system, or D, many respiratory conditions also affect the central nervous system. This one is C, correct. This one is C. Many CNS conditions can affect the respiratory system. Everybody okay? Snap that picture if you need it. Okay. Next question. Which of the following cranial nerves are evaluated with the gag reflex? Is that cranial nerve 9, 2, 5, or 3? This one's 9. Now, you know on the test I'm going to give you 10 as another option here, because those are the two I said you need to know. It is number 9. 10 was the one with cough. Right. All right. Next one. The phrenic nerve connects the diaphragm to which cervical nerves? Is that C1 through 3, C9 through 12, C6 through 9, or C3 to C5? I didn't say this during this lecture, but I did say it in another class. It is D, C3 through C5. And my last question, the Glasgow Coma Scale score of what would indicate the need for mechanical ventilation? Is less than 3, less than 8, less than 10, less than 14?
B.
Less than 8, you're going to intubate. Less than 8, you're going to intubate. I know the textbook says 8 or 9, but 9 intubate doesn't have the nice rhyme that less than 8 you intubate does, so. That's a B, correct. Can it be less than 3? No. So if it's less than 8, that's an indication for mechanical ventilation, endotracheal intubation, and in turn mechanical ventilation. All right, any questions? All right, so.
Okay, what should we focus on?